Thanks very much for talking with us today, Dr. Stewart. Just wanted to ask you, how did you become interested in research?
Well, I was graduated with my undergrad degree and looking for a job, and I had some computer skills, and I thought, what can I do with that? And so I applied for a job in a department of community medicine at Dalhousie, where I was living, because I had my undergrad degree at Dal. And it was a research assistant job, and I just loved it. I'd had all kinds of other jobs, I worked with my summer jobs, and I just loved doing research. I loved, calculating the statistics. That's how long ago it was. And I loved working with people. One of the things that job asked me to do was help people understand these new computer programs that were just coming out. So what does it mean that the computer's going to do this and that manipulation? So there were these sort of incomprehensible manuals. And I had to kind of go around and make sure that the professors knew what the manual was doing. Was it the same way they always did it? So I found that I could communicate and sort of translate things. So I liked the people aspect, working with people, but I also liked the quiet work of, sitting in your office and calculating or working on the computer or writing something. So I just love the combination of activities that research is.
Okay. Then how did you transition into family medicine research?
Yeah, that's a great story, actually.
Okay.
So I became a PhD student at Western in 1970, and my supervisor was Dr. Carol Buck, the chair of the department. So, I knew nothing about family medicine. But I did know that I was interested in doing studies that would somehow link up people's psychology, biology, social factors, and that's the kind of epidemiologist I wanted to be, somebody who integrated social, psychological, and medical issues. And so I came saying that's the kind of thesis I want to do. I can't imagine what it would be, but that's the kind of thesis I want to do. And Dr. Carol Buck said, my, we have a new professor here named Dr. Ian McQuinney. He came a year ago, and he started the Department of Family Medicine here, and he talks just the same way. And so I'm going to get you two together. So after a year or a year and a half of Dr. Carol Buck and Dr. Ian McQuinney and I working, I'm the student, I'm working with those two as co-supervisors, I realized that the work of family physicians was this integration that I'd wanted to study. I wanted to look at it from an epidemiological perspective, but they were doing it from a clinical perspective, family physicians. And so it was Ian McQuinney through my PhD, and he became my supervisor of my PhD program, which was with family doctors and with patients coming in for a variety of problems. And did the doctor know about all of the different problems? We called it holistic medicine in those days, but it really became whole person medicine, which is what I've studied all along. So my interest and passion in integrating all these different aspects was kind of answered by the role of family medicine as Ian McQuinney saw it. And there's another great story about those early days. It would have been about a year or two later when it became clear that I was going to be doing this for a long time. Ian McQuinney said, you're not going to be a family doctor. You're going to be an epidemiologist, but if you want to study family doctors and their patients, you should learn more about what they do. So he said, I'm going to send you to spend a week with 3 or 4 different family doctors. And so I shadowed these 4 family doctors in Cambridge, Ontario and Tavistock, Ontario. And we didn't have one-way windows or videos or anything in those days. This is 1971 or something. And I just sat in the corner of their offices as the patients came in and watched what they did and had a little chat with them afterwards about what they were doing. And all of this led to our research questions about the role of family doctors in integrated whole person care, which we then later called patient-centered care. So, a decade later, we were beginning to articulate it as patient-centered care. So kind of a long story, but a really great lesson for somebody who's not a family physician researcher, but a researcher who wants to work with family doctors, is really get to know what they do by working with them side by side for, days and days and days.
Okay. Tell us more about the patient-centered care studies that you've done since then.
Right.
It's become very important to practice now.
Yeah. So there's a couple of aspects of that I'd like to tell you about. First of all, the way we've defined it and the way it's known from Western and the college simulated office oral exams are kind of based on the same approach. That emanated from our department with Ian McQuinney asking the 15 or so clinicians in the department to do once a month faculty development for a whole year, so 12 long sessions, asking them what it is that they do with their patients and discerning what it is when a family doctor feels like they've succeeded with a patient.
Okay.
So this description that we have now, that we call the patient-centered approach, was like a little qualitative study where we found out from clinicians what they thought worked. If you ask a family physician, when you're working well, what is it you're doing with the patient? When it clicks, what is it you're doing? So we just asked a whole lot of family doctors that question, and together, through discussion, they came up with these elements, and I'll tell you 4 of them. One of them is exploring both the disease and the illness experience, and that illness experience is the patient's feelings and their expectations and their ideas and the effect on function. And then also considering the patient in context, so what are the family issues or the work issues? And third, finding common ground with the patient about the problems, roles, and goals, like, is this treatment plan that I'm suggesting going to work with you? Let's have a discussion about that. That's finding common ground. And all of this takes place in the context of a long-term continuity of care relationship that develops between the family physician and the patient. So that's what we mean by patient-centered. It bubbled up from clinical practice. It's not something we invented as researchers. It's not a research tool. It's a description by practitioners. And then later, we created the research tool. So the research agenda around patient-centeredness was, how do we measure it?
Okay.
So that's one stream of research that we've done. And the second stream of research is, how does it correlate with good outcomes? So that's we call that an analytic cohort study type design. And I can tell you more about each of these streams. But then the third stream was, okay, how do we improve it? How do we make an intervention as educators or as researchers? We call it an intervention trial. We do an intervention with half of the doctors. We don't do the intervention with the other half. And that's a randomized control trial, pragmatic randomized control trial. It looks at what's the impact, what change happens when you try to intervene and you try to improve. So those are the 3 aspects of our research agenda: the measurement, the correlation studies, and the intervention studies. And they've been going on for years and years. Some of them have been funded, and some of them we've just done because we wanted to answer a question. So that's a little bit about our research.
So what are your findings in terms of patient-centered care? What happens when patient-centered care is implemented and when it works, as
Right.
opposed to when it doesn't?
Right. Good question. Okay, so I'm going to frame that in terms of different kinds of outcomes. So we know from our studies, but all kinds of other studies too, that patient-centered care, the way I've described it, will be correlated with higher patient satisfaction. The patients will notice and the patients will say that was I'm satisfied with that care. Or they'll say, I experienced patient-centered care. They'll notice.
Mm-hmm.
So those studies have been done by us and by many others. Then we also have done studies, both intervention and analytic cohort studies, that look at the relationship between patient-centered care and patient health outcomes. So patient self-described health, patients' reports of functional status, actual blood pressure readings, and hemoglobin A1C levels. All of those things have been found in either correlation studies and or randomized controlled trials to be better when the care was patient-centered than when it was not patient-centered.
Wow.
So there's,
That's
really
amazing.
important. It's amazing. Blood pressures, 10 millimeters of mercury, better after an intervention about patient-centeredness. That degree of impact on a physiologic outcome, 10 millimeters of mercury, is the kind of impact that a drug company would die for if they had a drug that would be able to improve millimeters of blood pressure to that degree in a consistent way. And so, we've got to sell patient-centered care in the same way that pharmaceutical companies are selling their medications. We could talk about the mechanisms of how patient-centered care might make a difference to somebody's blood pressure, but we'll leave that for another time, or you can follow it up. Because the third outcome that's really important in Canada these days, but everywhere really, is that patient-centered care is correlated with efficiency of care. In other words, the policymakers should sit up and take notice that patient-centered care actually leads to lower costs. And here's the way it works. If the visit is patient-centered, the patient is a diagnostic test is ordered less frequently.
Mm-hmm.
A referral is less likely, and the patient is less likely to come back for a subsequent visit for the same problem because their needs were met in that first visit. They didn't have to come back and say, we kind of missed part of what I wanted to be handled. And probably the same reason for why a diagnostic test would not have to be ordered, because the doctor and the patient would have discussed things to such a thorough extent that the doctor was more comfortable waiting and seeing, or was more comfortable with a patient-centered understanding of the patient that didn't necessarily, in some instances, need a diagnostic test. And then the cost studies have been done both here and by us and in the United States. And if you cost out these things with dollars, patient-centered care, well, what happens is that the non-patient-centered visit is followed by higher costs of care than the patient-centered visit. So we've got these three outcomes. We've got patient perceptions that the care is better, we've got patient health outcomes, and we have less use of health resources and lower costs, which we think is a pretty convincing picture at this stage after several decades of research, not just by us, but by others in the UK and in the United States and all over the world, Spain. And
Wow. So you mentioned during this time about selling family medicine research,
Yeah.
just as drug companies have sold their drugs and the benefits of their drugs. How does family medicine research do that? How do we as a discipline put that kind of information out there so that everybody understands and everybody
right,
follows what you found?
So if I were the College of Family Physicians of Canada, I would call it selling family medicine. I'm a researcher, so I call it knowledge translation.
Okay.
I call it, and this is why I work in a clinical department, is because I want the research put into practice. I don't want it published in a paper, and that I never have a chance to talk to the people implementing the practices. So I'm interested in talking to practitioners and managers of health services and policymakers in the government who are either implementing a program or who are thinking of policy, sort of writ broad, higher level, strategic planning kind of ministry work and government work. So I think that all of us, researchers in particular, should be spending more time talking about our results everywhere, every opportunity we have. Now, if you're a family physician researcher and you make your money in practice, this means you kind of have to take time out of practice to be doing this kind of work.
Right.
I'm an academic, and I can choose how I spend my time. And as a researcher, I will choose to spend a certain amount of time doing knowledge translation, doing these kinds of speeches, doing workshops that impress on policymakers that it's patient-centered care is as important as other aspects of care.
Okay.
So we call it KT, knowledge translation.
Okay. The knowledge translation, like you say, has become more important. What about the next generation? I know that you are a teacher, a mentor, and you've worked with dozens and dozens of students and family physicians who are transitioning or who want to incorporate research into their practice.
Right.
What do you tell them? How do you influence their knowledge and their love of research, and how do you get them interested in these aspects?
Well, for one thing, our programs work with the interests of the student, first of all.
Okay.
So I rarely have a student who's working on my topics.
Okay.
The student will work on a topic that they're passionate about from their practice. It could be cancer care. It could be child health. It could be educational research. I was talking to 2 residents yesterday who are really passionate about how young family physicians become interested in becoming teachers. Work from their interest, first of all. Make it fun and accessible. There are some sort of mysterious aspects of research, just as there are mysterious aspects of clinical practice.
Mm-hmm.
All kinds of acronyms and all kinds of kind of technical things that have to be learned. And you can be a good communicator and make that more accessible than less accessible, and have them grow, sort of incrementally. Also, having young people work in teams. I'd like to give you a little history of some of the educational programs I've been involved with, but the most recent one is the Tutor Primary Health Care. And those students, 12 of them, come together every year, and they learn from each other how much fun it is to be a team of researchers. It doesn't have to be lonely work. You don't have to be just alone in your practice, being the only one interested in this.
Tutor is transdisciplinary?
It's an acronym for Transdisciplinary Understandings and Training on Research in Primary Health Care. Tutor Primary Health Care. And it's actually a CIHR-funded training program.
Okay.
That we had to compete to put into place. And it's been going for a number of years. And family physicians and nurse researchers and psychology researchers and epidemiologists and social workers who are working in primary care are selected to participate in this program. And so what we've learned from that are very interactive ways of education, team meetings, model team meetings, all kinds of fun exercises and workshops rather than kind of, one-on-one lectures or that kind of work. So you can make research fun and interesting. Now, it's pretty labor intensive. There are 20 teachers for 12 trainees. There are 20 teachers who work all year round, and some of those will go to the symposium So it's almost a one-on-one ratio for that particular program. It's pretty labor intensive.
Sounds like it.
But you know, I want to mention some of the history of education around research.
Right.
And one of the beginning programs was the college-sponsored programs in the 80s, in the 1980s. And these faculty development, they were called faculty development, so all us young faculty in those days came to Mont Saint Anne in Quebec, and the college funded this one-week education program for faculty to train them on teaching and research. And that really built community. It built a community across Canada, community of people interested in research and interested in teaching. And so that was a really great little bit of the college history that I wanted to make sure got remembered. And then the next aspect of teaching that we worked on, and we call it capacity building for research, making sure that there is a next generation of researchers for family medicine research and epidemiology research in primary care. And these was a series of 5 conferences called the Foundations of Primary Care Research.
Okay.
And that was a funded project too, and they were great, great conferences. And we had invited guests, about 10 invited guests that we could fund to come and teach us and give us lectures and be keynote speakers for different themes of the conferences. And out of that came 5 textbooks of primary care research.
Okay.
So that was kind of step number 2. And then from that has come some graduate programs, master's programs, and the tutor program. So we've had a lot, the college in collaboration with researchers across Canada has had a lot of has had a lot of commitment to growing the next generation of researchers.
Right.
Yeah.
So for the next generation of researchers, I've heard that people say that it's much more complicated for them than it was for the previous generation. What will the challenges be for the next generation?
I'm not sure I agree with that. I mean, I think that the opportunities are much more now than they were.
Why is that?
Well, for one thing, the Canadian Institutes for Health Research are much more interested in funding what they call a clinical investigator. So family physicians will be able to be funded as researchers, which is, almost kind of unheard of in our generation in the 1980s and 1990s. It might have been easier for someone like me as a full-time epidemiology researcher to get a career award. We call them career awards. But now CIHR is focusing on the clinicians. And I think that's a great opportunity for family medicine researchers, for family physician researchers. So I think there are some opportunities. They need to be well educated. They need to be well trained researchers to be competitive. I don't know what's more complicated. Things were pretty complicated in the old days. High volumes of patients, more so than now. If you're in a family health team or one of the new models of care, another advantage is that you have a population that is your population, because the family health team has to register patients. So that's an asset. You know who your patient population is. So I'm seeing the advantages more than I'm seeing the complications. I think that there's more other people interested, so you don't have to feel quite as lonely as you used to have to feel. I'm seeing lots of advantages. I think we should be, selling and trumpeting all of the possibilities, all of the opportunities and facilitators that are out there these days that weren't there before necessarily. And the pioneers kind of had to make their own opportunities. So that's one aspect. Not to minimize that there are challenges, and that a young researcher needs to needs to kind of make some decisions about how they're going to prioritize their time. Are they going to spend 2 days a week clinical and 3 days a week research? How's that going to work? How's that going to affect their income? Because it will. And those are the kinds of realities that have always been there, but continue to be challenges. Yeah. So good question.
Okay. I understand that you have recently done a lot of work on in electronic medical records.
Right.
And working with exploring how electronic medical records can be utilized for research. So can you tell me a bit about that?
Sure, yeah. Well, for me, it started with my Canada Research Chair application, in which I had to have a very technologically oriented project, or program of research. So it not being necessarily my bent, right? I talk about patient-centeredness. So electronic medical records was a great opportunity in 2002, 2003. There were very few family physicians then, less than 10%. And so we were kind of in on the ground floor, and we were interested in working with an electronic medical record company that would be interested in research, that would make some adaptations so that we could do research better. Could structure the electronic medical record so that it wasn't just the same as a note with sentences in it, but that the family physicians or nurses or social workers would have to structure the data. They'd have to put the blood pressure reading in a certain way, and it would have to go there. And they would talk about the morbidity, not in 3 different places in the cumulative patient profile and in the objective findings of the visit, but it would go in one place, and they would be coded in a certain way. They couldn't just write in, question mark, colon cancer. It would have to be coded. It would have to be structured. And that's the best way for researchers and for family physicians who want to get information out of their charts. So we were ahead of our time, because what family physicians are finding now, when they want to prove that they have met a target in diabetes care, they have to know who their diabetics are. They have to know that they have somehow identified these folks. So, we started 10 years ago making sure that people with different diagnostic problems were identifiable in the electronic medical record. So there's all kinds of issues with electronic medical records. There's a lot of excellent clinical data in there. There's the morbidity data. What are the problems patients are bringing? How many problems are they bringing? So the multimorbidity can be studied in ways that a study of a single disease misses all the other problems patients bring in.
Right.
This suits me. This is about whole person medicine. It's about the person and all of their problems, not about the one disease in isolation from all of those other problems. So I find that very satisfying about electronic medical records. They have great medication data. They have great diagnostic test data. And they have this great morbidity data. And very little on the social context or on the illness experience or on even socioeconomic status. That's just not in a typical electronic medical record. So there are some big gaps in electronic medical record data. It's great for clinical studies that are kind of just surrounded clinical studies, but they're not great for looking at the bigger picture, like access to care. Is it different for different vulnerable patients, different ethnic groups, immigrant patients, different socioeconomic status patients. So we do linked studies so that we can work around that. We link with ICES data. We would link with census data and get some of those other pieces of information from other places. So as a researcher, you can get a better, more rounded picture. As a clinician, you're going to be fascinated by finding out what your practice really looks like. You're going to be able to find out how many visits your diabetic patients are coming in for. Is it enough? Is it too many? You're going to be able to do some good practical answering of questions that you can improve your practice after you've found out the answers. So it's a great opportunity, electronic medical records, but there are also some serious research methodologies that we need to continue to work on. I could tell you much more about them if you want to know, but we need to know the denominator. We need to know the validity of the morbidity. If we're saying these are the diabetic patients, are they really? Have we tested that? Do we know that we haven't missed some? Mm-hmm. So all of those validation studies are being done now, and so it's just a great opportunity for research electronic medical records, and especially in connection with other data that's got other aspects of the profiles that you want to be able to study. So it's been great fun. We have a great team working on electronic medical records, and we have always had several clinicians on that team, and system managers and technical people who make sure that the data can be extracted from the practices with consents and privacy all taken care of. And so there's been many, many layers and much that we've learned, and it's entirely possible, and I just encourage everybody to start looking into that as a great source for answering clinical questions.
Okay, good. What will the questions be for family medicine researchers in the next 10 to 20 years?
Well, I think that there's much that we need to know about how family medicine can work with other professions. And I probably haven't worded this quite right, but I think that the kinds of questions that are going to be really good questions in the future are going to be, how does this healthcare system work?
Okay.
So family practice and family physicians are one piece of the whole system. So how is it that family physicians are working with other clinicians? How is it that family physicians can better work with nurse practitioners and team-based care? How can family practice link better with community care access centers, with pharmacists? And I see that as the future. I think family practice is the glue that holds the healthcare system together. It's the core, as I see it. But if it's going to be a system, it can't be family practice on its own. Family practice has to link with all of these other aspects of the healthcare system, hospitals and CCACs, or we call it in Ontario CCACs. It's home care,
right?
Public health, working with consultants and specialists in new and different ways. And I've got examples of studies that are along those lines that I have in my head as being the future really, really important studies. For example, in Ontario, there's this wonderful work being done on the e-consultation. It's an electronic email consultation that a family physician has with a specialist. And they talk back and forth about the problem. So the patient is not referred before they find out if there's a referral necessary. The family physician and specialist talk by email. It used to be in the old days that the family physician would pick up the phone and have a chat with their friend, the cardiologist. And this is the 2020 version of this, or 2012 version of this. But it's going to become the wave of the future. So that's just one example, and it's not an example from my work. It's an example that has impressed me from other researchers across Canada. So the other future for researchers is not sort of topic oriented, but it's the way we researchers work together. And CIHR, the Canadian Institutes for Health Research, and others are really encouraging us to work together, to do research that compares among and between provinces.
Okay.
That makes sure that, you know, Nova Scotia, New Brunswick, Ontario, Quebec, and all of the other provinces. Sorry, I can't list them all. That we researchers from the different provinces would work together and become bigger teams of researchers. So just as I see the future research topics being kind of connectedness, I see researchers having to work in a more connected manner to be able to answer those questions, both as family medicine researchers across Canada, but also working with cardiology researchers or home care researchers, and you know, sharing the research questions to create the answers that we need. So that's just one thought off the top of my head about where the future might be.
Good.
So we had a vision, first of all, of an interdisciplinary team of researchers. So you need to know what kind of group of researchers you want and make sure that you find the funding that can support those researchers. And we've had two growth spurts. One was in the after 1989, when we got actually a big grant that demanded that we work closely with community family practitioners, and it demanded that we create an interdisciplinary team of researchers. And so that was a great launching pad for us and in enacting the vision that we had of different kinds of researchers working together, answering complex questions in family practice. And then the next growth spurt that we had was in the 2000s, when we sought all kinds of different opportunities that were provided by the universities. So the universities would want us to have a researcher who would work in two different departments. And so we would link family practice with psychology, or family practice with social work, or family practice with health services researchers.
Right.
And we had that kind of expansion has been the way that we've expanded since 2002. So I'm just giving some examples of the way that people who are running research departments, like the research directors of departments of family medicine across Canada, can think about organizing their and increasing the resources for research within departments of family medicine. It's great, by the way, that the college is has research as a strong plank in their overarching strategic plan.
Right.
And that research has a good solid foundation in the College of Family Physicians of Canada.
So I understand that Dr. Doug Robb has donated a research award to the Research and Education Foundation at the college. Can you tell us about that?
Yeah. Dr. Doug Robb, very few people know who he is because he died several decades ago. But it might be important for folks to learn a little bit about him so that you could put it in the Research and Education Fund brochures and people can apply for this award. So I only know him through my experience of him. So I knew him when he was the chairman of the research committee of the New Brunswick chapter of the College of Family Physicians of Canada in 1977, 78, 79.
Okay.
And he was a tall, black-haired family physician with a big, bushy salt and pepper beard. And he worked in Hampton, New Brunswick, small town, near or just north of Sussex, New Brunswick, even smaller than Sussex, New Brunswick. And he was very interested in the philosophy of medicine and very interested in a broad vision of family medicine and its healing role. So he did psychotherapy, he did a lot of addictions research. He went to the Esalen Institute in California, which was big in the 60s, and was where you would learn about altered consciousness. And so he was very much an experimental. He had an innovative mind, and that was why he was interested in research. He thought, very early days, right, 1977, he thought that research in family medicine was important, and that that's the way we were going to find out more about the broad practice of family medicine. And I got to know him because I was a postdoctoral fellow at Dalhousie after completing my PhD in epidemiology at Western. And so this is my first research project, and I had to find support from family doctors who would cooperate in this research, and it was a little odd. The research was audio taping family doctors with their patients to find out how patients and doctors conversed, what was the communication between them, and then I would interview the patients later on to find out how well the patients had recovered. So this was a very early, we didn't call it patient-centered care then, but we called it doctor-patient communication studies. And so I had to convince some doctors that this was, this was okay for a researcher to come in with an audio tape and ask your patients whether you would want to do that. So I approached Doug Robb as the chair of the research committee of the New Brunswick College and asked if he would support this research and have an interview with me and find out more about it, and he loved it.
Did he?
He thought it was just the greatest thing because it was new and it was kind of having family doctors think about the way they talked with patients. It was kind of different, and he just latched onto it as a real project. And he helped me recruit like 12 family physicians in New Brunswick. And those family physicians have gone on to be presidents of the College of Family Physicians of Canada and chairs of departments of family medicine. And at that point they were young family physicians in the cities, the three main cities of New Brunswick, Fredericton, Moncton, and St. John.
Wow.
So it was a great story and a little bit of history. And I just thought that it would be a great opportunity for the college to learn the little tiny piece of Dr. Doug Robb that I knew.
And his enthusiasm lives on.
Yes.
His support and his enthusiasm.
That's right. After this, he decided that in his will, he would, a bequest would go to the college for research. And he died quite young. He was probably in his 60s when he died. So. It's decades ago. Yeah. So, little history lesson.
Well, thank you for that. That's
You're
a great
welcome.
lesson.
Great.
Very good. Thanks very much, Dr. Stewart. That's great.
Thank you, Stephanie. My pleasure.